In this video, we will discuss about urinary tract infections. Urinary tract infection could be due to bacterial or fungal causes. There are different types of urinary tract infections, which includes asymptomatic bacteruria, uncomplicated urinary tract infection, which is also called simple cystitis, complicated urinary tract infection, catheter-associated urinary tract infection, funguria, and recurrent urinary tract infections. These all types of urinary tract infections varies with their symptoms, signs, risk of infection, and treatment. Asymptomatic bacteriuria is defined by bacteriuria, which is bacteria in the urine, which is 100,000 colony forming unit per ml, but no symptoms referable to urinary tract infection, irrespective of pyuria. Treatment: it shouldn't be treated with antibiotics, but there are exceptions. For pregnant women, post-renal transplantation in the past 1 month, and treatment prior to invasive urologic procedures. These are the three exceptions. Otherwise, you don't treat asymptomatic bacteriuria. The second is uncomplicated urinary tract infection, which is also called cystitis. First, let's see the symptoms and signs. This includes frequency of urination, urgency of urination, dysuria or pain during urination, urinary incontinence, nocturia, suprapubic tenderness in otherwise healthy and pregnant women, and in men with urinary tract infection features, consider a diagnosis of prostatitis and evaluate the prostate with digital rectal examination. Diagnosis of uncomplicated urinary tract infection involves, with the above signs and symptoms, we do urine analysis, and the expected finding is pyuria or white blood cells in the urine, which is more than 10 per 1 high power field. Absence of pyuria strongly suggests against cystitis or uncomplicated urinary tract infection. Nitrite and leukocyte studies both positive on dipstick, and the sensitivity is 68 to 88%. Nitrate is positive with enterobacterials, which convert nitrate to nitrite. In women, the presence of dysuria and also increased frequency without vaginal discharge or irritation, the likelihood of urinary tract infection is more than 90%. So in these patients, we don't need to do urine analysis unless there is some immune compromisation or risk factors for complicated urinary tract infection, which we will see the next slides. For outpatients, we need to get urine culture if the patient is male, if there are atypical symptoms, if persistent symptoms after 48 to 72 hours after antibiotic initiated, or recurrence of urinary tract infections within 3 months of treatment. What are the differential diagnosis or alternative diagnosis for uncomplicated urinary tract infections? This includes vaginitis, urethritis, structural abnormality, pelvic inflammatory disease, and nephrolithiasis. What are the bacteria that cause uncomplicated urinary tract infection? What is the microbiology? This includes E. coli, Klebsiella, protease, Staph saprophyticus, Enterococcus rarely cause true infection. The treatment of uncomplicated urinary tract infection involves nitrofurantoin 100 mg BID for 5 days, and this should be avoided if the creatinine clearance is less than 40. The other alternative is cotrimoxazole 960 mg BID for 3 days, and this also shouldn't be given empirically if the resistance rate in that environment is more than 20%. The other is fosfomycin 3 gram stat, and the other alternatives include oral beta lactams and also single dose of aminoglycoside if features of multi-drug resistance organism. The next is complicated urinary tract infection. First, let's see the symptoms and signs of complicated urinary tract infection. The features of uncomplicated urinary tract infection are there, like frequency, urgency, dysuria, suprapubic pain, and others. In addition, we say complicated if there is any fever, chills, rigors, or symptoms of systemic illness, costovertebral angle tenderness or flank pain, pelvic or perineal pain in men, if the patient is pregnant, or post-renal transplant. 30% of patients with urinary tract infection and fever are bacteremic, which usually occurs in older individuals, and they do have flank or suprapubic pain, increased CRP, C-reactive protein, and also decreased blood pressure. Pyelonephritis is a complicated urinary tract infection and may itself be complicated by perinephric or renal abscess, and we see white blood cell casts on urine analysis. What are the causes? The causes include causes of uncomplicated urinary tract infection like E. coli, protease, Klebsiella, Staph saprophyticus, and also Serratia, Morganella, Providentia, Pseudomonas, Citrobacter, and gram-positives rarely. If Staph aureus, think of bacteremia, and increasingly resistant organisms are isolated in complicated urinary tract infection, especially to fluoroquinolones and cotrimoxazole. Investigation-wise, urine culture should be done for all patients with complicated urinary tract infection, and imaging like ultrasound or CT scan in selected patients, including those who are critically ill, those who have suspected obstruction of the urinary tract, and also persistence of symptoms and signs after starting treatment. What are the treatment options for complicated urinary tract infection? For outpatients, we can give them ciprofloxacin, levofloxacin, cotrimoxazole. For inpatients, we need to give them ceftriaxone, cefepime, piperazine, tazobactam, and carbapenem if features of extended spectrum beta-lactamase organisms, and narrow to oral therapy after improvement. And the duration of treatment for complicated urinary tract infection depends on the clinical course as well as the oral agent we choose. For example, we do treat them for 5 to 7 days if we use fluoroquinolones. Prostatitis, the preferred treatment is fluoroquinolone because of its better penetration into the prostate, and the treatment duration should be extended to 6 weeks. And avoid nitrofurantoin and fosfomycin for patients for complicated urinary tract infection. If there are any urologic devices, we need to remove or replace them. The other is catheter-associated urinary tract infection. What's the definition? Signs and symptoms of urinary tract infection with no other identified source of infection, and also urine culture showing more than 1000 colony forming units per ml for single catheterized urine specimen in place for more than 2 days, or if we do the urine culture after removing the catheter, which is done within the previous 2 days. The symptoms are the same as other UTIs. In addition, patients with neurologic bladder and decreased sensation or some neurologic problems, they may have new onset incontinence, autonomic hyperreflexia, malaise, lethargy, and bladder pain. Diagnostic wise, we do not routinely screen catheterized patients who are asymptomatic for the possibility of catheter-associated UTI. And also, the presence of pyuria or turbid urine or some odor does differentiate asymptomatic bacteruria, which is one of the types of UTI which doesn't need any treatment, from real catheter-associated urinary tract infection. And if someone suspects suspects catheter-associated urinary tract infection, we need to remove or replace the catheter as soon as possible and obtain urine analysis and culture from the new catheter prior to initiation of antibiotics. And catheter, because catheter may be coated with a biofilm that acts as a reservoir for microorganisms and can compromise the action of antibiotics, we need to remove it. The cause being the same as complicated urinary tract infection. In addition, candida can cause catheter-associated urinary tract infection. And sometimes catheter-associated UTI could be caused by multiple microorganisms. And the treatment is the same as complicated urinary tract infection. And after the culture arrives, one can narrow the broad spectrum to a narrow spectrum antibiotics. Add vancomycin if recent catheterization and instrumentation, then there is history of methicillin-resistant staph aureus in the urine. The duration is 7 days or 10 to 14 days if any other reason. The other is fungal infection, which is called funguria. Asymptomatic colonization, just finding yeast on urine analysis, is common and which doesn't need any treatment. And treatment is indicated when there is symptoms or in patients who are neutropenic and at risk of invasive fungal infections or before invasive urological procedures. And the treatments in the first line is fluconazole. If a resistance organism is suspected, one can use amphotericin B. The last type is recurrent urinary tract infection. By definition, when someone has 2 or more infections in 6 months or 3 or more infections in 1 year, and recurrence is typically uncomplicated, and also even if caused by the same organism, usually it is reinfection, a new infection rather than relapsing of previous infection or uh, persistence of the previous infection. And the treatment is some behavioral change like drinking adequate water and postcoital urination or voiding and avoiding spermicide use and wiping from front to back for female especially. And antibiotic prophylaxis, usually with a lower dose, you may use cotrimoxazole or nitrofurantoin and used in females with recurrent simple cystitis if behavioral change doesn't completely treat the recurrence. One can use postcoital or continuous if no temporal relation to sexual activity. Other interventions include vaginal estrogen for postmenopausal women and other uh, drugs. And patients with recurrent admission for complicated UTI, we need to review prior microbiology, culture result, and consider resistance organisms. And prophylaxis should be avoided because of increased risk of resistance. So thank you for watching the video and please like and subscribe.